Now we're going to talk about considerations for obstetric patients. So just a few examination and treatment considerations to think of is one, we want to have individuals that are pregnant, we would have them avoid flat prone lying in mid to late pregnancy. We also would avoid having them in the supine position, completely supine for more than a few minutes after the 4th month of pregnancy. And this is because this can cause a condition known as supine hypotension syndrome, which we'll discuss in the next slide. And the signs that would be present there would be nausea, bradycardia, and syncope. We also want to avoid activities that would strain the pelvic floor and abdominal muscles. We would want to avoid positions that involve rapid, uncontrolled bouncing or swinging because of the fact that a pregnant woman, her center of gravity is going to be and center of mass is going to be changing over the course of the pregnancy, week by week, even, especially later in the pregnancy as the baby is growing. And also we would want to just be careful with if we have them in rapid uncontrolled bouncing or swinging, they could potentially fall and hurt themselves or the baby. We also want to avoid aggressive stretching to the hip abductors because of the concern of the pubic symphysis integrity. We want to avoid overheating because if there are fetal concerns that are related to an increased maternal core temperature. And then lastly, avoid deep heating modalities or electrical stimulation over the trunk. So we need to keep in mind that supine hypotension syndrome can occur in individuals that are pregnant, specifically those that are in the second half of their pregnancy as the baby is growing. And this can occur because the inferior vena cava can potentially be compressed with the growing baby and the weight of the baby, the uterus, and just the growing abdomen itself. So if a patient is lying completely in supine, all of that weight could be pressing on the vena cava. And we know that blood doesn't flow as strongly through the vena cava as it would through the aorta, right? So we would want to make sure that we don't allow for the vena cava, inferior vena cava, to be compressed. So if you take a look in the picture here, we note that that inferior vena cava is going to lie mostly on the right side of the vertebral body. So it's recommended that if we have a patient in the supine position, that we rotate them 30 degrees to the left and put pillows underneath the right side of the body. That helps to shift the uterus to the left, and that can help to relieve caval occlusion. So it's certainly a good idea to have a patient also on a wedge in order to ensure comfort and also to prevent hypotension, supine hypotension syndrome. And again, if we have a patient in this position, even in the suggested position, and they're reporting nausea, their heart rate is slowing down, or they're reporting that they're feeling lightheaded or experiencing syncope, we would want to immediately have the patient sit up. Some common medical conditions that and symptoms that occur in pregnancy that are musculoskeletal related include backache, carpal tunnel syndrome, headache, and muscle cramps. So there are multiple other symptoms and signs or symptoms related to pregnancy, but I wanted just to focus in on those that from a musculoskeletal standpoint that can occur. Backache, it is reported in about 50 to 90% of pregnant women that they experience back pain at some point in their pregnancy, and it's very much treatable. But there are some certain considerations we need to keep in mind, some which we have mentioned already, and others that you guys will continue to learn about in your special populations course. We also want to consider the possibility of a kidney infection in a pregnant woman that's presenting with back pain, and potentially screen for kidney involvement if we are noting any other signs of concern. Carpal tunnel syndrome can occur in pregnancy, and this can occur bilaterally. And this is secondary to the increased fluid volume that the patient is experiencing, which causes compression of the median nerve in the wrist. So it's common that this may occur. And it can even persist into the postpartum phase of pregnancy as well. Headaches, oftentimes they're frequent in early pregnancy and tend to decrease by mid-pregnancy. It can be a concern later in the pregnancy because of the correlation with hypertension. And we'll discuss what to look for that in the coming slides. But it's important to recognize that, especially in the third trimester or later in the pregnancy, headache, a pregnant patient reporting headache needs to be screened a little bit further to ensure that this is not related to hypertension. And then lastly, muscle cramps. Muscle cramps occur because there's increased pressure of the expanding uterus on the lower extremity nerve. So muscle cramps are most likely to occur in the lower extremities because of ischemia. So in this case, kind of just teaching the patient just some easy ankle pumps, things to do in regards to kind of improve and encourage circulation. Now we're going to talk about a couple special questions that we may want to ask patients that are pregnant that we're treating. And they include, one, are there any complications with the pregnancy? That can be important for us to recognize because a positive response to this question may alter the rigor of your exam as well as the specific exercise prescription that you utilize in this patient. And it may necessitate the monitoring of this patient's vital signs. We also may want to ask if there are any complications with previous pregnancies or previous deliveries that's placing you at high risk now, or are you considered a high risk pregnancy? So it's important to note that again, because that may impact our exercise prescription as well as what we include in our treatment. Did you have any of your current musculoskeletal symptoms in a previous pregnancy? If so, what was done for them and was the treatment successful? That information just can be helpful in aiding our treatment planning. If it was successful, then we may want to continue to do more of the same. And if not, that can also potentially give us some helpful information. What medications are you currently taking? And what medications did you have to stop because of your pregnancy? So this is just important to recognize because certain times patients are unable to take particular medications that they were normally able to take because of the pregnancy, which can result in some other complications or potential symptoms. And then lastly, are you having any urinary or anal incontinence? And in this case, if we ruled out that this was a red flag in the sense that something else of concern is going on, if there are any other neurological symptoms, obviously in that case, that would take precedence and that's an emergency referral. But if they're experiencing incontinence that's related to either previous pregnancies or this current pregnancy because of weakness in the pelvic floor, that would warrant a referral to a pelvic health specialist. Okay, some special questions for postpartum patients include, were you on bed rest during pregnancy, and if so, how long? Debilitation can occur if we have a patient that has been on prolonged bed rest, and it may necessitate treatment modifications or considerations with how you're going to treat the patient currently. Did any of the following occur during delivery? Either a regional anesthetic injection, a forceps or vacuum extraction, episiotomy or tears of the perineum, or lastly, a cesarean. In this case, specific tissues may be affected by these procedures, and they may require treatment from a therapist that is specialized in pelvic health as well. Do you now have any symptoms of urinary or anal incontinence or organ prolapse? Again, once we rule out that anything would be alarming in regards to any type of neurological involvement, it would be appropriate to refer the patient to a pelvic health specialist. And then lastly, did you have your current symptoms during your pregnancy or after a previous pregnancy, and were there any treatments that were successful in alleviating these symptoms? Again, that may assist in determining the cause of their symptoms and interventions as well as prognosis. So what are some common referrals or conditions that we would want to refer to a pelvic health specialist? If we had a patient with anal or urinary incontinence, urinary urgency, again, that's not secondary to a neurologic problem, pubic symphysis pain, SI pain, rib pain, low back pain, all of those can be treated by an orthopedic therapist. But if you feel like that they're outside of the scope of what you're comfortable with, then it may be appropriate to refer them on. Diastasis recti abdominis is something that is going to be treated by a pelvic health specialist, as well as pelvic floor tenderness or pain or muscle weakness. And then lastly, if the individual is suffering from postpartum neuromusculoskeletal injury that was related to their pregnancy or delivery. So here are a few conditions that we want to keep in mind in regards to patients that are pregnant and what the signs and symptoms would be. The first one is preeclampsia. This is a condition when an individual has increased or hypertension in pregnancy. Symptoms include headache or blurred vision. So again, we would want to be alert to this if we've got a patient that's reporting kind of new onset of headaches, especially later in the pregnancy, if they have any blurred vision or if we note any edema that's of sudden onset, which can be global. If we're checking their blood pressure and their blood pressure is high, then we would be concerned. And it's also noted that an individual might have protein in their urine, which obviously we're not going to be able to test. But if we have a patient with any of these symptoms, that would be an immediate referral. So that could be immediate in the sense that we call the OB, ask the OB, would you like them to come to see you, or would you like me to send them to the emergency room? But that is something that we want to have addressed immediately. But it can, as long as the patient is able to, to talk to us, it can be appropriate for them to be seen by their OB, but it may be appropriate as well to send them to an emergency department. An ectopic pregnancy, so we covered this earlier, but it's just important to remember that ectopic pregnancies can refer pain to the shoulder, but oftentimes they are going to report some abdominal pain as well as maybe a missed or a light period. Dizziness, lightheadedness, or nausea. This again is a immediate referral because of the seriousness of an ectopic pregnancy. If we're working with a pregnant patient and they report to us that they have not noticed the baby moving quite as much, especially in the later months whenever the baby is much more active and you're able to feel the baby move, that could be a result of fetal distress, and it would be important to make sure that you alert the medical provider. So you can call the OB and again make the determination if the patient needs to go to the OB office or if they need to go to the emergency room. Osteoporosis can occur in pregnancy. Typically, they would report pain in their hips, lower back, and pain with weight bearing. So the similar symptoms we would expect with osteoporosis. We may even note an empty infield in the hip if that's where their symptoms are coming from, as well as a loss of height. DVT, individuals that are pregnant are at greater risk for DVT. So we would expect our normal signs and symptoms that would be present with a DVT. If we're noting any of those, we would want to refer immediately. And then lastly, postpartum depression and postpartum psychosis. Both of these can occur in any pregnancy, and it's more common than is reported oftentimes because of the stigma that's associated with it. And fortunately, in the recent years, there's been much more education about how this can be, it's not necessarily that it's normal to experience after pregnancy, but it can be common. And so there's been a lot more education and emphasis in regards to screening for postpartum depression and psychosis. In regards to postpartum depression, what the patient typically experiences is mood swings, loss of appetite, irritability. They feel withdrawn from their family. They may have a difficult time bonding with their baby, and they may even have thoughts of harming their baby. In regards to postpartum psychosis, this is more severe, and these individuals are suffering more from mania as well as depression. They can be having hallucinations as well as delusions that would include specifically the child. So in both of these instances, it is very important to alert the medical provider immediately. So I would not want this patient to leave the office without sharing this information with their OB or their referring provider in order to make sure that it is addressed appropriately. And this Edinburgh postnatal depression scale can be utilized in order to determine if a patient may have postpartum depression. In this case, if the patient scores 10 or higher on this scale, that would warrant a referral. This is commonly used. I know that with my kids, when I was in the hospital, I had to fill this out before I left the hospital. And then at my follow-up visit with my OB, 6 weeks postpartum, I also filled it out again in order to help to screen to detect any of this. So if you're working with a patient who is postpartum, this would be a very appropriate outcome measure to utilize if you're concerned that there may be some postpartum depression occurring. Gestational diabetes can occur when an individual is pregnant. This is basically women that have higher blood glucose levels during pregnancy that they did not and did not previously have diagnosed diabetes. Most oftentimes it goes away after pregnancy. However, it can increase the risk for type 2 diabetes in the future. It's recommended that this individual's program include cardiovascular conditioning, which can help improve the glycemic control better than just diet alone. So they'll be guided in regards to dietary changes, but exercise is also recommended. Individuals with gestational diabetes are at greater risk for congenital malformations of their child, having a large or heavy baby for gestational age, and then lastly, it can be associated with perinatal morbidity and death. So hypertensive disorders in pregnancy, again, preeclampsia is an example of a hypertensive disorder. It's important that we monitor individuals that are pregnant. We want to monitor their blood pressure. So always we're going to include that as part of our normal screening and intake with our patients. But in individuals that are pregnant, we would want to continue to screen for that throughout the course of the time that we're working with them. Some signs of hypertension include those visual changes, reports of headache, if their blood pressure is above baseline, and then also if they have a sudden onset of edema. A venous thromboembolism can occur. So again, monitoring for the signs of DVT is important in pregnant patients because this can be a complicating factor in one out of 1,000 or out of 2,000 pregnancies. The risk factors here include hypercoagulability, venous stasis, vascular damage, as well as changes in the coagulation system that are occurring due to pregnancy. This is also a concern postpartum, and again, just monitoring those signs for those signs of acute DVT would be what would be important in this population. As noted earlier, osteoporosis can occur in pregnancy. Most often this is considered to be transient, and we would note that it would affect the lumbar spine, the hip, and the wrist most commonly. Compression fractures can occur, so it's important, and as well as subcapital femoral fractures. So it's important to kind of recognize those signs and symptoms of fractures in individuals that are pregnant that could potentially be suffering from osteoporosis in this pregnancy as well. In general, individuals that are presenting with a fracture, they oftentimes don't have a history of trauma. It's more common that it would occur in the third trimester, and the diagnosis is going to be made by ruling out other mechanisms or other mechanical causes, along with not responding to treatments, as well as feeling an empty infield at the hip, the spine, or the wrist, and also if we noted a change in height. Pubic symphysis dysfunction occurs when individuals have pain. They report pain in the groin at the pubic symphysis that's occurring due to the hormonal changes that are causing increased laxity of the pelvis in order to prepare the mother for childbirth. This increased incidence in pregnancy and postpartum, again, secondary to the increased joint mobility. So this can result in either pubic shears, a pubic symphysis separation. So a pubic shear occurs and is less debilitating than a separation, which is much more complex and painful. And it also can cause osteitis pubis, which can be a result of the periosteal trauma that can occur due to pregnancy or delivery. So we oftentimes note that in later postpartum months. And then what they would report is going to be painful gait, pain with weight shifting, especially with rolling over in bed. That's specifically noted to be very painful, as well as painful with abduction of the lower extremity. Physical therapy considerations include being mindful of not overstretching in an individual that has pubic symphysis dysfunction, maybe gentle stretching of the adductors, but being careful not to overstretch. And then if, again, an orthopedic therapist is most certainly trained to be able to treat patients with pubic symphysis dysfunction, but if you felt like it was kind of outside of your wheelhouse and that they'd be better served by a pelvic health therapist, that referral would be appropriate as well. Diastasis rectus abdominis can occur after pregnancy as well, and this happens when we get the separation of greater than 2 fingertip widths of the 2 bellies of the rectus abdominis at the linea alba. This is typically painless, but it can be associated with low back pain in urinary incontinence. And it's important to recognize this because it can be treated with physical therapy, and there are also things that can make it worse. So specifically, anything that's going to put lots of stress on the abdomen, like performing pure sit-ups, is not recommended. And there are other ways that we would want to ensure that we were strengthening the transverse abdominis, which can help to resolve some of that separation. Most oftentimes it resolves spontaneously in women, but it can persist. And in order to test for it, that's what you see here in this lower picture. What you have the patient do is place their arms down by their side and perform just a curl up. And we would have the fingers of the therapist kind of palpating between the rectus, noting the space or the number of fingers that are placed that can be placed in between the separation. And in this case, again, an orthopedic therapist could treat this, but if you felt like it was something that needed to be referred kind of out of your wheelhouse, then you could refer them to a pelvic specialist.